Have you ever wondered why some people's blood pressure climbs even when they eat reasonably well, exercise occasionally, and watch their salt intake? You have probably heard the standard list 100 times. Cut the salt, lose the weight, take the medication. But do you know that there are less obvious drivers, hidden contributors that never make it onto the standard list, that can keep pushing your blood pressure up regardless of how disciplined you are about the obvious ones? When you peel back the layers of cardiovascular medicine, blood pressure does not move because of one thing. It moves because of dozens of inputs landing on your vascular system at the same time. Some of those inputs are intuitive, some of them are genuinely surprising, and some of them have nothing to do with what you put on your plate. The question is, which of these less obvious drivers are quietly working on you right now? I want to be honest with you, right from the start. This is not going to be one of those videos where someone tells you that high blood pressure is caused by one weird trick, or that fixing it requires buying a specific supplement with a discount code in the description. I find that kind of content genuinely frustrating because the actual physiology behind elevated blood pressure is far more layered, more interesting, and more actionable than any single trick could ever be. What I want to do today is walk you through 8 contributors to high blood pressure that the standard conversation consistently misses. The sleep disorder hiding in plain sight, the sugar pathway nobody is talking about, the pollutant you cannot see, the chronic inflammation pattern that develops quietly over years, and several others that, once you see the mechanism, change how you read any blood pressure reading you have ever received. That is the kind of knowledge that actually sticks. When you know the reason behind the number, you never forget the number, and these particular reasons, once you understand them, change how you look at your own cardiovascular risk. Nothing here is medical advice. This is biology. Let's build it from the ground up. The first contributor is one that affects a staggering number of adults and that most people never connect to their blood pressure reading. It is called obstructive sleep apnea. Researchers like T. Konechny and colleagues at the Mayo Clinic published a widely cited analysis showing that obstructive sleep apnea represents the most prevalent secondary contributor to elevated blood pressure in patients whose hypertension resists medication. The mechanism is mechanical, and it is neurological at the same time. During sleep apnea, the soft tissue at the back of your throat collapses repeatedly during the night. Each collapse cuts off airflow. Your brain registers falling oxygen and triggers a brief arousal to restart breathing. Across one night, this can happen hundreds of times. Each arousal activates your sympathetic nervous system. Your sympathetic nervous system is the fight-or-flight branch. It dumps adrenaline and noradrenaline into your bloodstream. Your heart rate climbs, your blood vessels constrict. Your blood pressure spikes, often to its highest values of the entire day, repeatedly, all night long, while you are unconscious and remember none of it. A review in the Journal of Human Hypertension describes how this sympathetic activation does not just cause overnight surges, it carries over into daytime. The repeated nocturnal stress retrains your cardiovascular baseline. So your daytime blood pressure, the number the doctor measures in the office, can stay elevated not because of what you ate that morning, but because of what your breathing did the 8 previous hours. Roughly half of patients with what doctors call resistant hypertension, blood pressure that does not respond adequately to standard medication, turn out to have undiagnosed sleep apnea contributing to the resistance. This is not a minor issue. This is a structural driver. The second contributor I want to walk you through is added sugar. Not the sugar you can see on the spoon, not the white crystals. The hidden sugar loaded into sweetened beverages, packaged foods, sauces, dressings, and the everyday ultra-processed products most people consume without thinking about it. There is now a meaningful body of research connecting sugar intake to elevated blood pressure, and the numbers are not small. A dose-response meta-analysis in the Mayo Clinic Proceedings by Tausif Khan and colleagues looked at over 600,000 participants across 24 cohort comparisons. The signal was consistent. Higher sugar intake tracked with higher systolic and diastolic blood pressure. A separate meta-analysis reported systolic blood pressure increases of around 7.6 millimeters of mercury and diastolic increases of around 6.1 millimeters of mercury in subjects consuming higher sugar loads compared to lower. Another prospective meta-analysis covering 6 cohorts found that sugar-sweetened beverage consumption increased the risk of developing hypertension by roughly 12%. The mechanism behind this is multi-step. Fructose, in particular, the sweetener used heavily in commercial beverages and processed products, is metabolized in the liver. In excess, it drives de novo lipogenesis, the liver's production of new fat. That fat accumulates locally and triggers intracellular stress. Insulin signaling becomes impaired. Uric acid production rises because fructose metabolism depletes intracellular phosphate and accelerates purine breakdown. Elevated uric acid has independently been associated with reduced endothelial nitric oxide availability, and nitric oxide is the principal molecule your blood vessels use to relax. Less nitric oxide means stiffer vessels and higher pressure. I want to slow down on this because I think the implication is enormous. We have spent decades telling the public to reduce salt for blood pressure. That advice has merit. But during the same decades, average added sugar consumption climbed dramatically, especially through liquid calories. Many of the people who cut salt meticulously never adjusted their sugar, and their blood pressure never moved. The driver was somewhere else entirely. Hidden contributors do not get better public attention just because they are inconvenient. The third contributor is one that often rides alongside the sugar story. It is insulin resistance. When your cells become less responsive to insulin's signal, your pancreas compensates by producing more insulin. Circulating insulin levels rise. This state, called hyperinsulinemia, contributes to hypertension through several pathways. Insulin is normally a vasodilator. Your blood vessels respond to it by releasing nitric oxide and relaxing. But in the insulin-resistant state, that vasodilator pathway is blunted. The sympathetic activating effect of insulin, however, remains intact. So you get the pressor effect without the dilator effect. Net result, your vessels stay tighter. At the same time, insulin enhances sodium reabsorption in the proximal tubule of the kidney. Your kidneys retain more sodium. More sodium means more water retention. More water retention means more blood volume. More blood volume means more pressure against vessel walls. Research synthesis published by Maria Saleme Joe and colleagues in the journal Hypertension noted that roughly 50% of patients with essential hypertension have measurable insulin resistance. That is not a coincidence. That is mechanism. And critically, insulin resistance can be present for years, even decades, before blood sugar numbers start looking abnormal on standard lab tests. So someone with a perfect fasting glucose reading can still be in a state that is pushing their blood pressure up through this path. The fourth contributor is one I imagine very few of you would have thought of on your own. It is the air you breathe. Particulate matter pollution, specifically PM 2.5, the fine particles under 2.5 microns in diameter that come from vehicle exhaust, industrial emissions, wildfire smoke, and even indoor combustion sources. These particles are so small they pass deep into your lungs and across the alveolar barrier into your bloodstream. Once in circulation, PM 2.5 particles trigger systemic oxidative stress. They generate reactive oxygen species. They activate inflammatory cascades. They impair endothelial function directly by reducing nitric oxide bioavailability. And they stimulate the sympathetic nervous system through afferent pathways in the lung. The data here has accumulated impressively. A systematic review and meta-analysis of PM 2.5 and blood pressure in the journal Hypertension synthesized evidence that long-term PM 2.5 exposure is more strongly associated with elevated blood pressure and hypertension development than short-term spikes. Some studies have reported measurable blood pressure elevations within hours of exposure. Research published by the EPA's clinical outcomes teams has measured vascular function impairment following controlled particulate matter exposure in human subjects. The mechanism is not theoretical. The inflammation and oxidative stress produced by chronic particulate exposure contributes to arterial stiffness over time. Stiffer arteries push systolic blood pressure up. They also lose the cushioning effect that protects diastolic pressure from rising. The cumulative cardiovascular cost of chronic air pollution exposure is now considered comparable in magnitude to other classical risk factors, but it rarely makes it onto advice lists. The fifth contributor is a pattern rather than a single molecule. It is chronic low-grade systemic inflammation. This is the kind of inflammation that does not produce dramatic symptoms. You do not feel it in the way you would feel an acute infection. But it is measurable in blood markers like high-sensitivity C-reactive protein, and it shows up consistently in people with elevated blood pressure. The mechanism connects back to the endothelium, the single-cell thick lining of every blood vessel in your body. When that lining is exposed to chronic inflammatory signaling, it shifts from a vasodilating state to a vasoconstricting state. Nitric oxide production falls. Endothelin-1 production rises. Adhesion molecules get expressed on the surface of the endothelial cells, recruiting more inflammatory cells into the vessel wall. Over time, the vessel wall thickens and stiffens. Its ability to accommodate the cardiac pulse diminishes. Pressure at the peak of each heartbeat, the systolic number, climbs. Research published in the Journal of Hypertension by Vertis and colleagues has documented the link between endothelial dysfunction and low-grade inflammation as drivers of arterial stiffness and hypertension. The 2022 review in the International Journal of Molecular Sciences by Passanella and colleagues described how this inflammation-endothelial dysfunction pair plays a diriment role across multiple cardiovascular conditions. The implication is that blood vessel health is not a one-dimensional question about cholesterol. It is a multi-input equation, and inflammation is one of the largest inputs. Many of the previously discussed contributors feed into this same inflammatory pathway. Sugar raises inflammatory markers. Sleep apnea raises them. Air pollution dramatically raises them. Chronic stress raises them. They are not 8 separate stories. They are 8 entry points into the same cardiovascular biology, viewed from different angles. The 6th contributor is nutrient level, and it is one most people have heard the name of but rarely connect to blood pressure. It is magnesium. Magnesium is a cofactor in more than 600 enzymatic reactions in the human body. It is involved in vascular smooth muscle relaxation, in endothelial nitric oxide synthesis, in potassium channel function, and in modulating the sympathetic nervous system's tone. A widely cited clinical review by Mark Houston published in Magnesium Research reported that magnesium supplementation in the range of 500 to 1,000 milligrams daily may reduce blood pressure by as much as 5.6 systolic and 2.8 diastolic millimeters of mercury, although the clinical studies show a wide range of effects. A 2017 meta-analysis in the American Journal of Clinical Nutrition reported a beneficial effect of magnesium on blood pressure, particularly in subjects with insulin resistance or documented magnesium insufficiency. A more recent AHA hypertension meta-analysis in 2025 confirmed the direction of the effect, with stronger responses in populations that were deficient at baseline. The typical modern diet contains less magnesium than it used to. Processed grains have had their magnesium stripped along with their germ and bran layers. Soil depletion has reduced the magnesium content of some produce, and certain medications, including some widely prescribed acid suppressors and diuretics, deplete magnesium further through the kidneys. So the gap between intake and requirement has widened. The mechanism by which that gap translates into higher blood pressure involves calcium handling in vascular smooth muscle. When magnesium is low, calcium accumulates inside the smooth muscle cells around arteries, and those arteries contract more than they should. Pressure rises. The 7th contributor is environmental, and it is one that has only recently entered the cardiovascular conversation with real weight. It is chronic noise exposure. Researchers like Thomas Münzel and his team at the University Medical Center Mainz in Germany have spent years establishing the cardiovascular consequences of sustained environmental noise from road traffic, aircraft, and rail systems. The mechanism runs through the stress axis and the sympathetic nervous system. Persistent noise, even during sleep, activates the body's alert systems. Cortisol rises, heart rate variability declines, endothelial function deteriorates. Over years of nightly exposure to aircraft flyovers, highway traffic, or chronic occupational noise, measurable elevations in blood pressure accumulate. A study reported by the American College of Cardiology found that high blood pressure risk increased by roughly 10% for each additional year worked in chronically noisy industrial environments. The mechanistic reviews from Münzel's group, including a major piece in the Journal of the American College of Cardiology, established that environmental noise exposure is associated with increased incidence of arterial hypertension, myocardial infarction, heart failure, and stroke. The biological pathway tracks directly with stress hormone activation and vascular dysfunction. We do not typically think of noise as a cardiovascular risk factor, but the data increasingly says we should. The 8th contributor, and the one I want to spend extra time on because it is the most personal, is chronic psychological stress. The kind that does not come from one event, but from sustained life demands, financial pressure, caregiving burden, chronic anxiety, interpersonal strain. Your body does not distinguish sharply between a saber-toothed tiger and a difficult email thread. The amygdala fires the same alarm cascades, cortisol rises, sympathetic tone rises, heart rate increases, vessels constrict. Over weeks and months, these acute responses become chronic shifts. As the AHA hypertension paper by Murray Esler and colleagues notes, the strongest evidence base supports chronic mental stress as a primary cause of sympathetic activation in normal weight essential hypertension. The review by Fontes and colleagues in the American Journal of Physiology highlighted that emotional stress may alter neuronal firing rate in central pathways controlling sympathetic outflow. What makes chronic stress particularly insidious is its compounding effect. It disrupts sleep, and we already covered what sleep disruption does to blood pressure. It increases sugar and processed food cravings, feeding the sugar pathway. It reduces physical activity, removing one of the most reliable blood pressure moderators. It amplifies inflammatory signaling through cortisol dysregulation. And it directly activates the sympathetic tone that stiffens vessels. These 8 contributors are not 8 discoverable secrets. They are 8 well-established areas of cardiovascular research that simply do not receive proportional attention in mainstream public health messaging. The reason is partly historical. We have built public cardiovascular messaging around salt and weight because those are high-yield population scale levers, but that focus has produced an unintended consequence. People who do everything right on the standard list can still have elevated blood pressure because the drivers working on them are not the standard ones. I want to say something carefully here, and I want it to land. The question is not which of these 8 is the cause of your blood pressure. The question is which combination of these 8 has been working on you for years. Blood pressure is the integrated output of multiple inputs acting simultaneously. Reducing one input by half and leaving the other 7 untouched will produce a smaller reduction than expected because the other inputs are still pressing on the system. The most powerful improvements I have read about in the research come from addressing multiple contributors at once, not from hyper-focusing on any single one. If you snore loudly, wake unrefreshed, or have been told you stop breathing during sleep, that first contributor deserves priority attention from a clinician. If your diet has been quietly high in added sugar, the second contributor is doing work even if your salt intake is perfect. If your fasting glucose is normal, but your triglycerides are high and your waistline has crept up, the third contributor may be active even without the classic diabetes markers. If you live in a heavily polluted urban environment or near a wildfire zone, the fourth contributor is operating daily. If your high-sensitivity C-reactive protein has been elevated at any check, the fifth contributor has a foothold. If your diet is mostly processed food, your magnesium status may be lower than you think, and the sixth contributor is real for you. If you live under a flight path or in a chronically noisy environment, the seventh contributor has been working while you sleep. And if you have been carrying sustained psychological stress for more than a year, the eighth contributor has been reshaping your cardiovascular baseline. Once you see all 8, the standard blood pressure message starts to feel incomplete. Not because salt does not matter, salt matters. Not because weight does not matter, weight matters. But because there is a much wider field of contributors that the standard conversation leaves unattended, and that wider field is where most of the unexplained variability lives. Let me close with something direct. None of this is medical advice, it is biology. Knowing the contributors that can drive blood pressure gives you a vocabulary for asking better questions of the people who care for your health. It helps you see that the next blood pressure number on your record is not random. It is the integrated output of many quiet inputs. And quiet inputs can be modified. Slowly, deliberately, one at a time if necessary, but modified. Your vascular system is one of the most responsive systems in your body. Endothelial function can improve in weeks with changes in diet, activity, and exposure patterns. Sympathetic tone can recalibrate as sleep improves and stress patterns shift. The biology is not rigid, it is plastic. But it needs accurate information to work with. These 8 contributors are part of that information. If this video helped you see blood pressure as a wider conversation than the one you were handed before, make sure to subscribe to the channel. And leave a comment telling me which of these 8 contributors you had never connected to blood pressure before today. That kind of feedback shapes what I dig into next. Thanks for watching, and I'll see you in the next video.